Thank you, Pediatric team, for this past 2024, which is very nicely curated. And thank you, Veena ma'am and Frederick sir, for giving me this opportunity. So now we are shifting on to other specialties. Pediatrics is over. So I'll be talking on keratoconus and its diagnosis and management. So keratoconus, its definition, it is a bilateral condition, highly asymmetrical, and it is characterized by progressive thinning and ectasia of the cornea. And it leads to irregular astigmatism and decreased visual acuity. And contrary to the belief, it is inflammatory. And what is pediatric keratoconus? So this is corneal ectasia that occurs in children less than 18 years. So how different is pediatric keratoconus? Number one, so whenever you see pediatric keratoconus, they present in advanced stages. So mostly this is due to late diagnosis, and it is also highly asymmetrical. So children tend to tolerate with a good eye's vision, and they are not able to complain about their decreased vision in one eye. And we also see a very rapid progression in pediatric keratoconus. So it is almost 88% progression in 1 year compared to 8% of progression that is seen in adults. And there are a lot of systemic syndromes that is associated. And also pediatric keratoconus is most often associated with vernal keratoconjunctivitis or ocular allergy. And yes, we are dealing with children. And if not diagnosed properly, so we'll be affecting, it is definitely going to affect their quality of life. And they also don't cooperate very well for the diagnostic modality that we commonly use, that is corneal topography. So we don't get reliable diagnostic results also. And also the management protocol is slightly different. So that is what we'll be discussing now. What is the prevalence of KC? So it is highest in Middle East and Asian countries and lowest in Russia. And in India, it is almost 2,300 per 100,000. So if you see, if the prevalence on an average general population, if it is 1 in 2,000, in children, it is 1 in 625. So coming to pathogenesis of keratoconus, so there are a lot of structural changes and molecular changes that is dealt with. This is not, I'm not going to talk in detail about this. In general, we have keratocyte depletion and dysfunction, increased collagenolisis, degenerated extracellular matrix, so leaving us with a biomechanically weak and thin cornea. So, and there are a lot of environmental factors also, allergy, atopy, eye rubbing, all of it leading to increased inflammation, increased collagenolisis, and giving us a weak and thin cornea. And also there are a lot of genetic factors considered, because there was concordance seen in twins, but there's not a single gene that is isolated that is causative of keratoconus yet. So to summarize, keratoconus is multifactorial and polygenetic. So moving on to the clinical signs, so the common earliest clinical signs that we see are the scissoring reflex and the oil droplet reflex. So this is the small video that demonstrates the scissoring reflex and the oil droplet reflex. So this is seen when you do a retinoscopy. So when we do a retinoscopy in a normal eye, you see a vertical band of light that moves uniformly well. So here you can see a straight vertical band that is moving from left to right. So this is how it behaves in a normal eye. Whereas in a keratoconus eye, you will not be able to see a uniform distribution of this band of light, and there'll be scissoring. So there are two light reflexes, two bands that are seen that moves like blades of scissors towards and away from each other. So this is classical of keratoconus, and this is because of the irregularity in the central cornea that is seen in keratoconus. And scissoring reflex is one of the earliest retinoscopy signs that we see. And this is the oil droplet sign, where you see a dark annular shadow around the central bright reflex. In between two bright reflexes, you see a dark annular shadow. This is because this is located around the area of the cone. So moving on to the other signs, you have Fleischer's ring, that is the iron deposits in the epithelium, more appreciated in cobalt blue or green filter. And then you have the Vogt striae, which are stress lines. And then you can see corneal thinning. So corneal thinning is can be easily missed in routine screening in the milder stages, whereas in severe cases, we can definitely appreciate the corneal thinning. And then the advanced keratoconus can have signs like Munson signs and Resetti signs. And corneal apical scarring and hydrops are again seen in advanced keratoconus. And some rare signs are these prominent corneal nerve fibers and rupture in Bowman's membrane. So to summarize, in a very early stage, when the disease is in the subclinical stage, you can see a normal cornea with a normal corneal thickness. This is when there is milder corneal thinning that starts. So that is milder keratoconus. And then there is significant thinning, very severe thinning and apical scarring. And rarely we can have a complication like acute hydrops. Now, to be familiar with the terms that we use in keratoconus, so subclinical keratoconus is where there are no clinical signs, but the keratoconus is diagnosed only by using a corneal topography. The child or the patient might not complain much. They will be able to read 6/6, might be some slight blurring. Whereas in early or mild keratoconus, you can see definite topographical changes, and retinoscopy, scissor reflex, and the oil droplet reflex can be seen. There can be mild localized corneal thinning. So here, so the child will complain that not able to see all the letters, all the lines in that last Snellen line is not very clear. So this is mild change in vision, distorted vision. Whereas in moderate keratoconus is where we are able to appreciate all the clinical signs very evidently, and patient is not able to read 6/6 with glasses. Whereas with contact lens, they might be able to read 6/6. Whereas in advanced KC, here even with contact lens, 6/6 or 6/9 is not good. So they have a significant monocular diplopia or ghost images. And what is formifraste? Formifraste is they have a normal topography. There are no clinical KC signs here, whereas the other eye has KC. So this eye is considered as formifraste. And what is KC suspect? Here the contralateral eye is normal, whereas this eye has suspicious topographical signs. So this is a summary of the terms that we use in keratoconus gradings. So only the mild, moderate, and advanced KC are considered as clinical keratoconus. So moving on to the clinical signs. So one of the main diagnostic modality that we have here is corneal topography. So in corneal topography, I'll be talking about the Scheenflink imaging, that is the pentacam. So here we have 4 maps: axial curvature, anterior elevation, posterior elevation, and corneal thickness. And you have the parameters on the left side. So I'll be talking about the major findings that you see in keratoconus maps. So there is significant inferior superior asymmetry of more than 1.5 diopters. And this is seen in the 5 mm zone. So inferior is 46.8 and the superior is 44.2. And the difference is 1.6. And the steepest K is more than 47.2. And what is SRAX? That is the skewed radial axis index. So this is the angle that is formed between the steepest semimeridian above and below the hemimeridian. So here you have 2 segments A and B. The B segment is slightly skewed, and the axis corresponding to it is 30 degrees. And the extrapolated axis of the inferior steepest meridian is 70, and the difference is 40. The other way is to get this axis of the inferior one and find the difference and subtract it with minus 180. So then you will get the same 40. So if it is more than 21 degrees, it is considered to be significant for keratoconus. And the elevation maps, in normal maps, you see a symmetrical hourglass pattern, whereas in keratoconus, you'll be seeing tongue-like extensions and isolated eyelines. And the anterior and posterior elevations, you can see the numbers. The positive ones are called elevations, and the negative ones are called depressions. When the elevations in the BFS, if the anterior is more than 7.7 and posterior is more than 17.7, it is called significant for keratoconus. And the pachymetry map, you can find thin zone in the colors of yellow or orange or red. And here you can see it is significantly displaced inferior temporally. So it will have a nice dome shape. And in the corneal thickness spatial profile map, you will have a quick slope or an S-shaped slope curve. So that is significant for keratoconus. So the parameters in KC that we see in the left side, so you look for the quality of the scan, it should be okay. If the quality of the scan is not good, it is not completely reliable. The K1 and K2, if it is more than 47.2, the astigmatism, if it is more than 1.5. And then the Q value, that is the asphericity of the cornea, if it is between -1 and 0. And then, so see for the K max, so here it is more than 47.2. The thinnest local, if it is less than 500. And so the Y coordinate of the thinnest location. So that gives you the inferior and temporal displacement. So if it is more than 1 mm, then it is considered to be specific for keratoconus. So moving on to the management of a child with keratoconus or a documented progression. So first, you look for any allergy or associated ocular condition, which is the inciting factor for this progression of keratoconus or development of keratoconus. So first aim is to control this allergy and then proceed for collagen cross-linking. So collagen cross-linking is the only modality that we have at our hand in order to halt the progression of the keratoconus. So if it is a quiet eye, you can directly proceed with collagen cross-linking. If it is advanced keratoconus or there is corneal scarring, then we have to go for keratoplasty. So in either way, so our role doesn't end with this collagen cross-linking or keratoplasty. It is our responsibility as ophthalmologists to provide functional vision and good vision for the patient. So after keratoconus, we wait until at least 6 to 8 weeks for keratometry to stabilize, and then we give contact lens or spectacle. And above all, whenever we are dealing a child with keratoconus, parental counseling is very, very extremely important, more than how you counsel a myopic child. A lot of chat time is required because they have keratoconus is a condition that is going to be progressive, and the patient has to come for regular follow-up. And if the parent is not willing to spend that time with the child, then we'll be losing the child's quality of life, the vision, everything. So parental counseling is very important. And yes, we should talk about eye rubbing and counsel the child and the parent to look for eye rubbing. Any unconscious eye rubbing is done. So usually they have knuckle rubbing instead of finger rubbing. So this is done during the early morning. We ask the parent to observe for this and try to avoid that habit. And if there are any associated atopic diseases, if the child is very prone for allergy, then they can be referred to an immunologist or a dermatologist in order to tackle that as well. And also a systemic evaluation is must, because it is most often associated with systemic conditions like Downs, Leber's congenital amaurosis, connective tissue disorders like Marfan's, Ehlers-Danlos, and there are so many other systemic conditions. So that has to be neatly evaluated. And above all, we also recommend a sibling screening because it can run in family and the incidence is almost 15 to 50 times higher in family. So we always ask the parents to bring the other sibling also for a regular evaluation. So what are the management strategies? So yes, VKC and blepharitis has to be looked for in these children. And VKC cannot be treated like a routine condition. We have to make sure that these children are completely regularly followed up. And VKC children with keratoconus, with myopia are too many problems in one basket. So, so you can't think only about keratoconus and manage. So you'll have to make sure that the VKC is completely controlled, because if the ocular allergy is not controlled and you proceed with a collagen cross-linking, you will have to face n number of complications like non-healing epithelial defects, corneal ulcers. So, and the keratoplasties are not good. So the outcomes are all goes into haywire. The ocular allergy is not controlled. So, and then patient has to be looked for blepharitis. The children has to be, the lids has to be looked, and lid hygiene has to be advised. So allergy is one crucial thing when you're dealing with a child with pediatric keratoconus. So in collagen cross-linking, studies have proven that the standard Dresden protocol with epi-off procedure is that works best in these pediatric keratoconus. The epi-on procedure or the trans-epi CXL or the accelerated modalities do not have a very favorable outcome in pediatric keratoconus. So we always tend to go for the epi-off and standard. And yes, we have to be really, because we're going to, in epi-off procedure, we are going to create an epithelial defect, put a BCL. So these children have to be advised to wear goggles, so that post-operative period also has to be managed really well. And keratoplasty, so they have lesser ocular rigidity. So the keratoplasty is as such little difficult. So it is planned under well-controlled general anesthesia, good preoperative ocular massage, and then a same size graft is used for keratoconus patients. And we expect early suture loosening in these patients. So we have to look for all those things, try to plan a suture removal early also. And since they are children, we try to keep them on good topical steroids only for the first 3 months. Then after that, we try to slowly shift to low-dose steroids like Lotipred, and we try to keep them on cyclosporin or tacrolimus instead of keeping them on long-term steroids, because it can have side effects like cataract and glaucoma. And then contact lens. Contact lens, yes, we have tried contact lens but protectively we have tried. It is so beneficial for the children here. And we have a couple of patients, like 10 to 15 patients, where if the parent is very well educated, during their amblyopia patching, we try to give them rigid gas permeable lenses to wear contact lens. And we try to make sure that during the patching, that child is given some incentive, like watching TV or do something very likable for the child, so that they stick on to wearing these contact lens. Even a soft contact lens is easier, whereas an RGP is difficult even for adults. So a lot of counseling and share time has to go in when prescribing contact lens for these kids. So if the BCA with glasses is only 6/18, whereas with contact lens, the children will be able to read 6/6. So that is the importance and the usefulness of contact lens in keratoconus. So moving on to our learnings from cornea department, Arvind, Pondicherry. So we wanted to find out, like Dr. Venkatesh was telling, that there was an epidemic of keratoconus post-COVID. We wanted to find out whether keratoconus really increased after COVID. So we found that there was a little bit of a rebound phenomenon. The ratio of eye drops remained the same, and CXL percentage was marginally higher. And less than 20 years, we were seeing quite a large number of children. And bilaterality, almost 85% of them had bilateral disease, and boys had a higher chance of having keratoconus in this age group, and the gradings were almost similar. So the other study that we did was the topographic changes in healthy siblings, and we found that almost 4.7% had clinical keratoconus and 22% had subclinical keratoconus. And so this was 12 times higher than the average Indian prevalence. And so now we have a routine sibling screening that is followed in our clinic. The other study was, we used to get a lot of referrals from pediatric clinic for screening of keratoconus in less than 14 years. So we wanted to know, because the time-honored definition starts from puberty, only after that it develops. So we wanted to see how much was the prevalence, and we found that almost 13% had definite keratoconus, almost 6.8% had what KC suspect, and higher age, positive history of eye rubbing, K-reading can be done anywhere, so in an auto keratometer. So more than 47 diopters and corneal thickness of less than 470 microns were significantly associated with having a diagnosis of KC. So that was another study. What was the prevalence of KC in BKC? So we found that almost 34% had definite keratoconus in this BKC population screened. And we found that the palpebral BKC and KC had the highest association. And yes, almost all patients had eye rubbing history. And also we wanted to find out the prevalence of keratoconus in Down syndrome. So this was one of a screening that we did for World Keratoconus Day last year. And we screened 43 children. And in that we had 11 children diagnosed with keratoconus and 10 had bilateral disease, and 61% were boys. Moving on to some case scenarios. So this is case number 1. So this was a 12-year-old girl who was a daughter of a pediatrician here. And she complained of sudden onset defective vision in right eye for 2 weeks. And this was her presentation. So if you see, the corneal edema was almost close to 1,000 with acute eye drops presentation. So this was 1 week later. So we just treated her with hyperosmotics, and her uncorrected visual acuity was 6/60. But she beautifully recovered, and her BCVA with glasses was 6/24. And so this was 1 year later, her BCVA improved to 6/18. And with contact lenses, rigid gas permeable lenses, she's able to read 6/6. And now she wants to wear contact lenses to the school also, because she's very familiar. From 6 months onwards, we started RGP, and she's comfortable with wearing contact lens. So these kind of children has to be screened for the other eye. So the other eye was completely normal. She was reading 6/6, and she doesn't have any topographical signs of keratoconus also, but we're slowly following her up. So since this was a unilateral case, that is why she presented very late to us with an acute eye drops. So this was a 5-year-old with high astigmatism referred to us for -4 diopter cylinder. Right eye BCVA was 6/18 and left eye was 6/12. And his topography was completely normal with high with the rule astigmatism. There are a lot of children with high astigmatism, but with normal topography with no signs of ectasia. It is only high with the rule astigmatism that is completely normal. But we could find that he had some blepharitis, so he was counseled for to avoid eye rubbing and to have a good lid hygiene. So this is a 25-year-old male with VKC for 10 years. So his bilateral best corrected visual acuity was only 2/60. So this is a typical VKC eye that you would see. And you can see the extreme corneal thinning and the topography images of both. So you have the central corneal thickness of only 190 in both eyes. So for this patient, so we first brought a VKC under control, kept him under tacrolimus ointment, HS for 2 months. We gave him preservative-free lubricants. So primed him well and then took him for DALC for the right eye. His BCVA is 6/9 with after DALC. So this is a 17-year-old female who presented with BCVA of right eye 6/12 and 6/6 in the left eye in 2019. If you see, so this was KC grade 2 and grade 2 to 3 topographical grades. So unfortunately, this patient did not come to us for follow-up. And within 2 years, BCVA decreased significantly in both eyes. And now she went into the stage where we have to do a hypotonic C3R because her corneal thickness was in the borderline 360. So whenever we see a corneal thickness of less than 400, we also do an ASOCT to make sure that the corneal thickness is of adequate value and then only proceed with a hypoosmolar riboflavin, hypotonic C3R. But hypotonic C3R's visual acuity and prognosis is much lower than for an isotonic C3R. So this is an 8-year-old male with high astigmatism, -4 cylinders. So this eye, right eye was completely normal. So if you see right eye's topographical astigmatism also was similar to the subjective RR. And for the left eye, we found some abnormality. It was showing KC 3 to 4. But this was abnormal. You can see that the lower lid areas, no? So in very young children, we tend to actually pull the lids up like this and try to take the scan. So we tend to actually compress the lids, compress the cornea with the lids. So that was causing this distortion. Though the QS was okay, this was abnormal. So we called the child 1 year later to see if everything was normal, and it was completely normal. So this is another 14-year-old female with no risk factors, just high astigmatism with -1.25. So in the first time, we did not do corneal topography, but in the second visit, 1 year later, it was -1.1. 6 months later, it was -1.75 cylinders. So the K reading was completely fine. So if the K readings are fine and the astigmatism that you get in an autokeratometer is almost similar to what you're getting in your subjective refraction, we do not worry much if there are no risk factors, but still we recommend to get a baseline corneal topography. And this corneal topography also was similar to the K readings that we obtained. So this is a 35-year-old female Down syndrome. So she presented to us in 35 years of age, bilateral 5/60. And her topography was, so she was not amenable for any C3R because her corneal thinning was very high. So we told like, yes, no need to worry. Normally in a normal adult population, after 30 years of age, you get a physiological strengthening. We don't recommend C3R. We don't recommend C3R very aggressively in patients more than 30 years. We wait for documented progression and then only proceed for C3R. So that is what we planned for this patient as well. But unfortunately, she came 6 months later with acute hydrops in the left eye. So in Down syndrome, they have a habit of eye rubbing. So these patients, you will have to have a close watch for progression even after 30 years of age. So I would like to end with this mass screening protocol that is recommended by the Corneal Ectasia Preferred Practice Pattern and Pediatric Eye Evaluations PPPP in AAO. So mass screening for KC is recommended for all children with allergic eye disease, school children with myopia and myopic astigmatism, with family history of keratoconus, children with Down syndrome, and geographic areas where there is a documented high incidence of KC, and children living in high altitude or high UV exposure. So in all these areas, mass screening for KC is recommended. So these are my references.